Welcome to Roadmap to Residency. In this video, we are going to cover high-yield test-taking strategies for neuromuscular disorders on the United States Medical Licensing Examination Step 2 Clinical Knowledge Exam. This is not a full review lecture. Instead, we are focusing on how to recognize question patterns and apply strategies when you see neuromuscular topics on exam day. We will cover Guillain-Barré Syndrome, Myasthenia Gravis, multiple sclerosis, and peripheral neuropathy. Make sure you have already reviewed these topics in first aid, pathoma, and your question bank. This video is about applying that knowledge strategically. Let us get started. Here is what we will cover today. First, we will learn to recognize the classic question stems that board examiners use for neuromuscular disorders. Second, we will apply specific test-taking strategies for distinguishing between ascending and descending weakness, identifying autoimmune patterns, and choosing the right diagnostic and treatment steps. Third, we will work through the next best step format that is so common on this exam. Remember, the foundational content lives in your textbooks and question banks. This video is about strategy. Let us dive in. The first strategy is learning to split ascending weakness from descending weakness. This is one of the most important pattern recognition skills for neuromuscular questions. When you see symmetric ascending weakness starting in the legs, areflexia, and a history of recent infection, think Guillain-Barré Syndrome. The boards almost always give you a post-infectious timeline. On the other hand, when you see fatigable weakness that worsens with use, especially ptosis and diplopia that get worse as the day goes on, think Myasthenia Gravis. This descending pattern starting in the cranial nerves is the hallmark. This ascending versus descending split will help you narrow your differential immediately on exam day. Strategy 2 is about recognizing autoimmune neurologic patterns. The boards love to test multiple sclerosis and Guillain-Barré syndrome as autoimmune conditions. For multiple sclerosis, the key clue is a young woman with episodic neurologic deficits that are separated in time and space. Classic findings include optic neuritis, internuclear ophthalmoplegia, and sensory symptoms that come and go over weeks to months. For Guillain-Barré syndrome, the key clue is rapid onset symmetric ascending paralysis after a viral illness. The boards will often give you the lumbar puncture results showing albuminocytologic dissociation, which means elevated protein with a normal cell count. These autoimmune patterns are tested heavily, and recognizing them quickly will save you time on exam day. Now let us look at high-yield stem recognition. For Guillain-Barré syndrome, the classic stem gives you a patient with a recent gastrointestinal or respiratory illness, followed by ascending symmetric weakness and areflexia. The cerebrospinal fluid will show elevated protein with a normal cell count. For Myasthenia gravis, the stem presents fatigable weakness that worsens with repetitive use, particularly ptosis and diplopia that get worse throughout the day and improve with rest. The boards may mention a thymoma or positive acetylcholine receptor antibodies. For multiple sclerosis, look for a young woman with episodic neurologic symptoms separated in time and space, such as optic neuritis, internuclear ophthalmoplegia, or Lambert sign. The diagnosis is confirmed with magnetic resonance imaging showing periventricular white matter lesions. Learn to spot these patterns instantly. Here is our first practice question. A 32-year-old man presents with progressive bilateral leg weakness over the past 3 days. He had a diarrheal illness 2 weeks ago that resolved on its own. On exam, he has symmetric weakness in both lower extremities with absent deep tendon reflexes. Sensation is intact. What is the most appropriate next step in management? Take a moment to think about this before we walk through the answer. What pattern do you recognize? What is the key finding that points you toward the diagnosis? Let us walk through this answer step by step. Step 1, spot the pattern. We have post-infectious ascending symmetric weakness with areflexia. This is the classic Guillain-Barré syndrome presentation. The diarrheal illness 2 weeks prior is the key timeline clue that the boards are giving you. Step 2, apply the rule. When you suspect Guillain-Barré syndrome, the next best diagnostic step is a lumbar puncture to look for albuminocytologic dissociation, which means elevated protein with a normal white blood cell count. Step 3, eliminate wrong answers. Brain imaging is for central nervous system pathology, and this is a peripheral nerve disease. Electromyography is helpful, but it is not the immediate next step. Acetylcholine receptor antibodies are for myasthenia gravis, not Guillain-Barré syndrome. The correct answer is B, lumbar puncture. Here is our second practice question. A 25-year-old woman presents with 3 weeks of worsening double vision and drooping of both eyelids. She reports that her symptoms are minimal in the morning but become progressively worse throughout the day. She has no sensory deficits and her deep tendon reflexes are normal. What is the most appropriate initial diagnostic test? Think about the pattern here. What is the key feature that distinguishes this from other causes of weakness? Let us walk through this answer. First, read the question carefully. The question describes classic myasthenia gravis with fatigable weakness, bilateral ptosis, and diplopia that worsen throughout the day. The normal reflexes and intact sensation tell you this is a neuromuscular junction problem, not a central nervous system disease or a peripheral neuropathy. Now, why does antibody testing win? Acetylcholine receptor antibody testing is the most specific initial diagnostic test for myasthenia gravis and is the preferred first step. The edrophonium test, while historically important, is less commonly used today due to cardiac side effects. Lumbar puncture is for Guillain-Barré Syndrome. Brain imaging would be for multiple sclerosis. The correct answer is B, acetylcholine receptor antibody testing. Let us cover the key treatment pearls you need for the boards. For Guillain-Barré syndrome, the treatment is intravenous immunoglobulin or plasmapheresis. A critical board fact is that corticosteroids do not help and may worsen outcomes. The most dangerous complication is respiratory failure, so always monitor respiratory function closely. For myasthenia gravis, pyridostigmine is the first-line symptomatic treatment, and immunosuppression is used for long-term control. For multiple sclerosis, acute relapses are treated with high-dose intravenous corticosteroids. Disease-modifying therapies are used to reduce relapse frequency over time. The boards love asking about this distinction between acute flare treatment and long-term management. Know that corticosteroids shorten the duration of a relapse but do not change the long-term prognosis. Here is our third practice question. A 28-year-old woman presents with a 2-day history of painful vision loss in her left eye. 6 months ago, she had an episode of numbness and tingling in her right leg that resolved after several weeks. On exam, she has a relative afferent pupillary defect in her left eye. What is the most appropriate next step in diagnosis? Think about the key pattern here. What 2 features does this question give you that point toward the diagnosis? Let us walk through the answer. First, spot the classic pattern. We have a young woman with 2 separate neurologic events affecting different parts of the nervous system, optic neuritis now, and sensory symptoms 6 months ago. This is the hallmark of multiple sclerosis, lesions disseminated in time and space. The relative afferent pupillary defect confirms optic nerve involvement. Now know the key distinction. Magnetic resonance imaging of the brain and spinal cord is the best initial diagnostic study because it can show the characteristic periventricular demyelinating lesions. Lumbar puncture can support the diagnosis by showing oligoclonal bands, but it is not the first step. Visual evoked potentials are supplementary tests. Acetylcholine receptor antibodies are for myasthenia gravis, not multiple sclerosis. The correct answer is B, magnetic resonance imaging of the brain and spinal cord. Here is an important test-taking pearl about peripheral neuropathy patterns. The boards frequently test diabetic neuropathy as the most common cause of peripheral neuropathy. Look for a patient with diabetes and symmetric stocking glove sensory loss starting in the feet, with loss of vibration and proprioception first. Other high-yield neuropathy patterns include vitamin B12 deficiency, which presents with peripheral neuropathy, and posterior column signs like impaired proprioception and vibration sense. Lead poisoning causes a motor-predominant neuropathy with wrist drop. Alcohol use disorder causes sensory-predominant neuropathy. The key strategy here is to match the type of nerve fiber affected with the specific underlying cause. The boards love testing your ability to connect the clinical pattern to the etiology. That wraps up our test-taking strategies for neuromuscular disorders. Remember, the key to these questions is pattern recognition. Ascending weakness with areflexia after an infection points to Guillain-Barré Syndrome. Fatigable weakness worsening throughout the day is myasthenia gravis. Episodic neurologic deficits disseminated in time and space is multiple sclerosis, and symmetric stocking glove sensory loss points to peripheral neuropathy. Review the neurology and neuromuscular chapters in first aid and your question bank. Focus on distinguishing upper from lower motor neuron findings and matching clinical patterns to specific etiologies. If you found this video helpful, Please like and subscribe for more board review content. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you on your journey. Good luck on your exam, and we will see you in the next video.